Dr. Ken Landau. Thanks for watching. Let's talk about glaucoma. Glaucoma is a leading cause of irreversible vision loss. It's asymptomatic until relatively late in its course. That means early on you don't have any clue. You don't have any eye symptoms. You don't have any eye pain. Loss of vision is a relatively late feature of the disease. So the diagnosis is frequently delayed until problems already are irreversible. But early detection is mandatory in order to stop the progression. And if we can make the diagnosis of those people who are at risk, we can actually do something to prevent them from developing the problem in the first place, simply by reducing the pressure inside the eye. Reduce it by 20, 30, 40% with some eye drops. That's all it takes in the overwhelming majority of people. So glaucoma isn't just one disease, but rather it's a group of progressive eye diseases that are associated with loss of the fibers of the optic nerve. It's an optic neuropathy. You get a characteristic visual field defect. You lose some of your peripheral vision out here. We have structural changes that occur in the optic nerve. The changes are characterized by loss of the retinal ganglial cells. So the light passes into the eye, impacts on the retina, but the retina has to move the image into the nerve. The nerve is the retinal ganglial cell. So the retinal ganglial cells go out through the back of the eye. They form the optic nerve. They go up to the brain. So if we start losing some of those retinal ganglial cells associated with glaucoma, then we're going to make some changes in the optic nerve. Instead of it being nice and flat, now it's going to be cupped. So the loss of those retinal ganglial cells, that's going to be related to the level of the intraocular pressure and to other factors. But the only factor that we can change at the present time is the intraocular pressure. We don't really know what some of those other factors are that lead to glaucoma. Well, there are multiple causes of glaucoma, risk factors. It affects different populations in different manners, causes different sorts of symptoms depending on which type of glaucoma you have. The duration can be long, altered in different people. Treatment can be a little bit different depending on the type of glaucoma that you have. The prognosis is different. The likelihood of you having glaucoma and not knowing about it, if you happen to live in America, is somewhere between maybe 10 and 50%. So it's a significant problem. If you live in an underdeveloped area of the world, probably about 90% of the people don't know that they have glaucoma. But remember, it's an irreversible blindness that results from not knowing you have the disease, a disease that can be screened for simply by just going to see your eye doctor. It's especially important, remember, because it's asymptomatic until relatively late in the disease. How common is it? Well, it's pretty common, actually. If we look at the most common type of glaucoma, it's called open-angle glaucoma. It occurs in a little more than 3% of the population. That's about 6 times more common than the second most common type of glaucoma, and we call that closed-angle glaucoma. That affects about half of the 1% of the population, half of 1% of the population here in the United States. So overall, there are about 3.5% of the people who have glaucoma. Now we can divide the two major types, the open-angle and the closed-angle glaucoma, on the basis of the anterior chamber. That's the area between the iris and the cornea. That's where the fluid leaves the eye. The eye, an area of the eye, manufactures some fluid. We call that aqueous humor. Well, the aqueous humor is important for our vision, important for the eye, but it has to get out. We have to maintain relatively normal pressure inside the eye. So if there's constant production, then we also have to have an area for egress, an area for exit of the fluid. Well, that's what the problem is in glaucoma. It seems like it doesn't get out. So in open-angle glaucoma, we have resistance of the area where the fluid is supposed to exit. We call that the trabecular meshwork. So the fluid can get to the trabecular meshwork, it just can't get through the trabecular meshwork. The door is in effect closed. On the other hand, with that closed angle glaucoma, or the angle closure glaucoma, if you will, there is no access to the area where the fluid is supposed to leave the eye. The area itself seems to work perfectly okay, but it's just that the fluid can't get there. It can't get there because the iris, when it dilates, when it opens up, so you have a dilated pupil, when it's dark, well, the iris blocks the pathway. Or in some cases, the iris can push on the cornea, or sometimes the lens and the iris push on each other, and the fluid can't even get from the posterior chamber of the eye to the anterior chamber of the eye, where the exit happens to be. So open-angle glaucoma, the aqueous humor, has free access to the trabecular meshwork and to an area in the trabecular meshwork we call Schlemm's canal. But we have resistance to the outflow. We have a normal angle. Typically, these people have increase in their intraocular pressure because the fluid keeps being made, but it can't get out. But interestingly, a substantial portion of people with glaucoma have what we call normal pressure glaucoma. It seems the outflow resistance is normal, or it's only slightly increased in those individuals. But they still develop the changes of glaucoma. So like I said, the whole condition of glaucoma is a lot more than just the intraocular pressure. So about 80% or more, maybe even as high as 90% of people in the United States with glaucoma have the open-angle glaucoma. Angle closure glaucoma, much less frequent, but interestingly, it's associated with a greater percentage of people who have severe visual loss. The peak incidence of open-angle glaucoma is in Africans and African Americans. It's about 4.2, 4.4%. Angle closure glaucoma tends to affect the Asian population. Highest incidence, 1.1%. So if we look overall at glaucoma, we find that men are affected more than women by about 40%. African Americans affected more than Caucasians by about 2.5-fold or 3-fold. So the most common incidence in the United States is in the African American population, then the Caucasian population, least in the Asian population. If we look at a 60-year-old Caucasian, likelihood of glaucoma is about 1.5%. In an African American individual, it's about 2.5 to 3%. If we look at a person who is 80, if Caucasian, the likelihood of glaucoma is about 5%. Likelihood of glaucoma in the African American population at age 80 is about 13%. Condition is relatively unusual prior to age 50. Most of the diagnoses are made after age 65 or thereabout. Well, primary open-angle glaucoma, that's very common. That's the 3.1%. We have the angle closure glaucoma. That's 0.5%. Those are primary types of glaucoma, but we have secondary kind of glaucoma. So you could get glaucoma simply because you're putting too much cortisone in your eye. Maybe you have eye allergies and you're putting eye drops that have some steroid in your eye. That can cause glaucoma. Maybe you're rubbing some steroid around your eyelid because you have a rash on your eyelid. Maybe you have rosacea. Maybe you have seborrheic dermatitis or some other kind of condition, and you put some steroid, some cortisone around your eye. That can cause glaucoma. That can cause increased pressure. Trauma to the eye, inflammation of the eye, or tumors, or a variety of ocular conditions can lead to glaucoma. You know, family history is significant. So if you happen to have a sibling who has glaucoma, your likelihood of having glaucoma is probably 8 times greater than the general population, and even greater than if your parent or if your child. So if your sibling has it, that significantly raises the issue. And if we look at people who are nearsighted, the more nearsighted you are, the greater your risk. So we talk about people who have high myopia. They have greater than a -8 diopter refractive error. Those people have significant incidence of glaucoma. And people who have moderate to high myopia, they also have substantial increased risk, not as great as the high myopes. People with obstructive sleep apnea, people with diabetes, people with high blood pressure. But interestingly, people who have significant low blood pressure during the nighttime, maybe because of normal pressure that goes down in the course of the night. We know that there's a fluctuation. Blood pressure is higher in the daytime, lower in the nighttime. That's very typical. Maybe it's because you're taking medicines. Now there's a tendency to start taking the blood pressure medicines during the evening hours. That's probably good for the heart, but it might not be so good for the eye. People with cardiovascular disease seem to have a higher risk of glaucoma, and people with certain vasospastic conditions, so people with migraine headaches or people who have Raynaud's condition. Now, if we look at the intraocular pressure of the eye, most people have a pressure somewhere between 11 millimeters and 21 millimeters of mercury. Your blood pressure, if we look at your systolic blood pressure and check it in your arm, that's 120 millimeters. Well, in your eye, it's somewhere between 11 and 21. Now, if we look at the mean, so the average intraocular pressure is about 15.5 to 16. But there are a substantial number of people who have an increase in the intraocular pressure who never are going to go on to develop glaucoma. And conversely, it seems that if we look at the people who have glaucoma, depending on what kind of population we're looking at, somewhere between 25 and 50% have normal intraocular pressure. Their pressure is less than 21 or 22. Well, back in the late 1800s, Duke Elder, a doctor, an eye doctor, he described an increase in the intraocular pressure when people go to sleep. So the pressure at nighttime seems to be the highest in both patients with and without glaucoma. Pressure rises when you go to bed. When you lie down, the pressure goes up by up to about 6 millimeters. So the peak intraocular pressure occurs between about 11 o'clock at night and about 6 or 7 or 8 o'clock in the morning. Interestingly, that's when the systolic blood pressure tends to be the lowest. So 2 points. One is when you use your eye medicine for glaucoma, since the pressure is up mostly at night, that's when you should use it. Most of the eye drops are meant to be used at night. And you have to be a little careful if your blood pressure drops too far during the nighttime hours. Now, if we look at someone, say, between about 3 o'clock in the afternoon and 9 o'clock in the evening, the intraocular pressure tends to fall by about 3 millimeters under normal circumstances. The normal daily fluctuation in an otherwise healthy individual is somewhere up to about 5 millimeters. It's more in patients with glaucoma. And we know that there's a slow increase in the intraocular pressure over the course of your lifetime. Now, the intraocular pressure can fluctuate on an instantaneous basis. It fluctuates when you blink or when you rub your eye or when you have rapid eye movement. There's the diurnal daytime-nighttime shift I just mentioned. Then we have other short-term fluctuations that occur over the course of days to weeks, and even more long-term fluctuations that occur over months to years. So the intraocular pressure is a balance between the amount of production and the amount of drainage. And that's very important. We have several different mechanisms for drainage of the eye. We have the trabecular meshwork in Schlemm's canal. That takes care of about 90% of the fluid. But then we have the uveoscleral outflow that takes care of about 10% of the outflow. And interestingly, many of the drugs work on that second pathway, the uveoscleral outflow. They don't really boost the trabecular meshwork outflow. Now, we have two groups of people with glaucoma. Remember, we have people who have the normal intraocular pressure, that's a substantial number, and we have the people who have high intraocular pressure. What does that mean? It means that intraocular pressure is a risk factor for development and risk factor for the progression of glaucoma. It's not a disease marker. It seems that the intraocular pressure, whatever the level is, even when it's within the normal limits, may be too high for those retinal ganglial cells in the intraocular structures. Now, you could get glaucoma because of some genetic predisposition. So as I mentioned before, it's high if you have a sibling with the condition, but we know that there are a variety of genes that can contribute to glaucoma. And these genes don't necessarily have anything to do with intraocular pressure. And misfolding of some protein can occur in those people with glaucoma. Genes make up at least 5 to 10% of all of the causes of glaucoma, perhaps more once we understand really what they are. But there's different genetic implications for both open-angle glaucoma and closed-angle glaucoma. Different genes are involved. The gene control can be of the central corneal thickness, or your optic disc size, or the cell-to-cell adhesions, or collagen metabolism, type 2 diabetic pathways, or acetylcholine metabolism in the body. So it doesn't have to do specifically, the genes don't have specifically to do with the intraocular pressure. But when symptoms finally do occur when you have glaucoma, typically you're going to lose your visual fields. That's out here in the mid-periphery. And then they proceed, and then they keep on destroying your vision. And pretty soon, they can affect the quality of your life. You can't drive anymore, significant disability. But we only poorly understand what the contributing factors to the progression are. Because even if we keep the pressure under control, some people are going to progress anyway. It seems that those retinal ganglial cells, remember, they're part of the central nervous system, well, it seems damage to them and damage to their axons that make up the optic nerve that go up to the brain, degeneration of those cells that lead to the cupping, because now in the back of the eye, we don't have the area full of the axon cells, but it now becomes empty, so it looks like a half-empty teacup in the back of the eye. We can detect that late on with looking with an ophthalmoscope. That's not an early diagnosis. So the increased intraocular pressure, what does it do? How does it seem to cause some problem? Well, it causes mechanical strain and stress in the back part of the eye, where the optic nerve happens to be. It's covered by something called the lamina cribrosa. And the lamina cribrosa is just basically a screen through which all of those axons from the retinal ganglial cells penetrate. And when we have too much pressure in the back of the eye, then we're going to get some compression and deformation and remodeling of the lamina. And it's going to kink some of those cells. And when the axons get kinked, then some of the important material, some of the important nutrients from the central nervous system can't make it all the way through to those retinal ganglial cells. Those retinal ganglial cells need the support of some of the chemicals from the brain, like the glutamate. Now it can't get there anymore, so the cells start to die. And furthermore, the pressure seems to affect the ability of the mitochondria to work, either because the lack of nutrients or the lack of oxygenated blood. So now we have the loss of the mitochondria, and it seems that the retinal ganglial cells need a lot of energy. And where does the energy come from? The energy comes from the mitochondria. So again, we're putting the retinal ganglial cells and the axons at risk. Now, when we have normal pressure glaucoma, what's happening? Well, what we think is happening, at least in part, is that the optic nerve is part of the central nervous system, of course, and those retinal ganglial cells are too, and it's covered by the subarachnoid space, and that has cerebrospinal fluid. And we think that maybe in some of those individuals who have the normal pressure glaucoma, maybe the pressure inside the subarachnoid space and the cerebrospinal fluid might be unusually low, so we still have a significant differential in pressure. And that might cause some of the problem. It might cause some of the problem because it alters the microcirculation, and that can lead to a cascade of damage where the retinal ganglial cells start to go, then the astrocytes and the microglia start to go that are supporting it. Then we have cells all the way up through the brain and the visual cortex that start to be lost. There are two theories. One has to do with mechanics. Just simply it's too much pressure inside the eye, and that causes the damage to the optic nerve head. And the other one is the vascular theory, that the cells of the retinal ganglial area, the cells in the optic nerve, they're just not getting enough oxygen, and that might be the cause. But we really don't know. How do we make the diagnosis? Well, the most important thing is the visual field examination. So visual field examination can vary from time to time. So you have to go and see the doctor at least a couple times over a period of weeks, months, or years, and have your visual fields checked to make certain that there isn't an abnormality. And it's not just the visual fields, by the way, because once those retinal ganglion cells start to go, there's an impact on the color vision, dark adaptation, contrast sensitivity. All of that's very important. Now, how do we make the diagnosis? Well, we can look in the back of the eye with an ophthalmoscope like your doctor does, your family doctor, your eye doctor does. But that, unfortunately, only gives us an idea about late changes. We don't get the characteristic changes that can be detected through simple mechanisms like an ophthalmoscope. Now, if we were to use some optical coherence tomography, that would give us a little bit earlier of a clue. But unfortunately, that's a technical area, and unfortunately, a lot of practices just simply don't have the equipment. Well, if we look in the back of the eye, in more advanced cases, we have a loss of what's known as the rim, the neuroretinal rim around the optic disc. And then the disc seems not to have as much in it, so it seems like it's an excavated cup. And now that's going to progress unless we stop the condition. And the only way we stop the condition is we bring the pressure down. How do we measure the pressure? Well, we do it with something known as tonometry. But that's only a weak criteria because, remember, a significant number of people have normal pressure. But it's an essential part of the diagnosis, but it's not the main criteria, because if we go to Japan and look at the Japanese population, probably more than 90% of the people with glaucoma have an intraocular pressure of less than 21. Well, tonometry is dependent on the corneal thickness and the corneal curvature. So if the cornea is abnormally thick, we're going to get a false positive diagnosis. We're going to make the diagnosis of intraocular pressure increase when you really don't have any. And if you have an abnormally thin cornea, we're going to underdiagnose the condition. So now we have to measure the central corneal thickness and the curvature in order to make the diagnosis. We don't have a simple standard. The early diagnosis actually is kind of challenging. We examine the optic nerve head, and that can reveal significant signs of neuronal loss. But remember, that's late on in the course. We even have significant arguments among the glaucoma specialists about what constitutes significant change. But we do have those characteristic changes in the visual fields, and that's very important. That confirms the diagnosis. But now we've already had at least 30 to 50% loss of those retinal ganglion cells before we can make the diagnosis by visual field detection. So that's a late kind of a loss. Now we might be able to improve the situation, as I said, with some of the fancier techniques like the optical coherence tomography and the confocal scanning laser ophthalmoscopy. And now, interestingly, just within the latter part of 2019, a group came forward and said, you know, with color photographs of the back portion of the eye, artificial intelligence might be able to make the diagnosis even before we can on any of the other fancy methods. So that's something that we'll learn more about in 2020 and 2021. But the only proven therapy we have right now is to reduce the intraocular pressure. That prevents the development of the disease, and that can slow the progression of the disease. So in those people who have ocular hypertension, the pressure is high, but they haven't had any kind of visual loss. They don't have anything that we would label as glaucoma. If we follow those people for about 5 years, some people we give medicine to reduce the pressure, other people we don't. What we find is that in the people whose pressure is reduced with medicine, only about 4% of them are going to progress to glaucoma. In the people who don't get the therapy, about 10% are going to progress to glaucoma. And if you have early changes of glaucoma, and we follow you for about 6 years, a part of the group getting treatment, part of the group not getting treatment, well, among the people getting treatment, the rate of progression is 45%, but in people not getting treatment, the rate of progression is about 65%. So again, reducing the pressure can slow the progression of the disease, but it doesn't eliminate the disease. And once a person has the diagnosis, then it's one of those kind of conditions where you got to go back and you got to get checked periodically. You got to make certain that the treatment is working, because if it's not working, then you need to change the treatment. Well, at the present time, the American Academy of Ophthalmology recommends that we pick a specific target level and shoot to that target level. We want it sufficiently low so it avoids progression, and we can estimate the desired pressure level on the basis of the type of glaucoma you have, the level of associated retinal damage or retinal ganglial cell damage, the severity of the damage, the risk factors that you have for prognosis, how old you are. Obviously, if you happen to be relatively young, you're 50 or 60 years old, we want to be a little more aggressive than if you happen to be 92 years of age and you haven't really lost significant vision at the time. Then sometimes the therapy can be associated with being a pain in the neck. And for those people who are going to, in effect, outlive their glaucoma, then maybe we don't need to be as aggressive. And then we always have to consider the potential for side effects from the therapy. So the AAO, the American Academy of Ophthalmology, recommends we start with about a 25% goal. The goal is 25% reduction in the pressure. Could range anywhere between about 20 and 50%. And we continue to reassess it depending on evolution of the disease. If we continue to progress, obviously, we've got to change our therapy. And how do we recognize whether you're progressing? Well, we monitor the optic nerve for changes, and we monitor your visual fields. So the goal is use the fewest number of medicines, have the minimal number of side effects, and we have a variety of medicines. So you choose the medicine on the basis of cost and adverse side effects and the dose schedule. Some people find that if they close their eye for a moment or so after they put the medicine stays in the eye rather than leaving the eye through some of the tear ducts and getting out into the systemic circulation. Sometimes if you just put your finger on your eye on your closed eye for a moment or so after you put the drop in, then it also stays locally rather than getting out, so you get more benefit of the medicine. Well, we have a variety of different kind of medicines. We have the prostaglandin analogs, we have the beta blockers, we have the carbonic anhydrase inhibitors, we have the alpha-2 agonists, we have the cholinergic agonists, or what we call the myotics, and now there's a relatively new class, came out in 2017, the Rho kinase inhibitors, and we have laser treatment where we can actually work on the trabecular meshwork, and there are surgical procedures, filtering procedures that can be done. Fortunately, the overwhelming majority of people who have glaucoma can be treated with the medicine, the eye drop. So the first choice of therapy usually are the prostaglandin analogs. These medicines decrease the intraocular pressure by getting more of the fluid out through those uveoscleral pathways, not through the trabecular meshwork, but the uveoscleral pathways. You put one drop in at night, you don't use more, has few, if any, significant systemic side effects, may cause some local side effects, cause some redness, and if it persists for more than 2 or 4 weeks, maybe it's an allergy to either the preservative or the drop, can cause some elongation, some darkening of the lashes. Sometimes it can cause loss of the fat around the eye and deepening of that crease in your upper eyelid. Sometimes it causes darkening of the iris itself, and sometimes it causes darkening of the skin. Well, the choices are latanoprost, that's xylitane, that's the most popular drug, but we have Lumigan, which is bimatoprost. It's also known as Latisse when you use it for your eyelashes. There's Zioptin and Travatan Z. That's the closest one to the latanoprost, but they've changed the preservative to make it a little bit less irritating. All of those medicines, one drop at night, preferably at night, works much better if you use them at night, but it's better that you use it at least once a day even if you can't use it at night, but it's better if you use it at night. Other classes of medicine seem to be somewhat less effective, but sometimes the prostaglandin analogs, like the latanoprost, aren't adequate by themselves. Maybe you have to use another medicine. Well, the prostaglandin analogs and the carbonic anhydrase inhibitors and the myotics, they all seem to reduce the pressure daytime and nighttime. The beta blockers and the adrenergic agonists, they work more in the daytime, less in the nighttime. So a beta blocker, what would a beta blocker be? Actually, the beta blockers were the first choice of therapy up to 1998 when they introduced latanoprost. There are medicines like timolol. Timolol is a medicine that you might have heard of to reduce your blood pressure or to lower your heart rate when it's given orally. Well, it can be applied topically to the eye. Unfortunately, some of the medicine might be absorbed. That's why you put the pressure on. That's why you do some of those changes that I mentioned a moment ago, because some people can have some life-threatening reactions. They can have some bronchospasm. They can have some slowing of the heart rate, lowering of the blood pressure, can actually prevent your noticing impending hypoglycemia if you're diabetic and you're taking some medicine, because it stops some of those symptoms. Initially, use the medicine twice a day. Some people use it once a day. Avoid nighttime use to minimize the reduction in the blood pressure that occurs at night. So that's not really the best of all choices. Well, we have the carbonic anhydrase inhibitors like Trusopt. That's dorzolamide. That's the least effective. It works to not only decrease the production of the aqueous humor, but it's also a very safe and well-tolerated medicine. You could even take it orally. Orally has some more side effects, so it tends not to be used. Might cause some nausea or some weakness or some peripheral tingling. We have the alpha-2 agonists. These are medicines like brimonidine. Well, that decreases the production of the fluid, and it also increases the uveal scleral output. But it's really only a third or a fourth line drug. It's the least well tolerated, causes the most corneal or conjunctival redness, causes some local allergic reactions, may even cause some dry mouth or drowsiness. And the myotics, the things that shrink your pupil, medicines like pilocarpine, well, they're not too much used for the open angle glaucoma because they have a significant number of side effects. Well, it does have the longest period of use, and it does, the pilocarpine, does decrease the intraocular pressure by increasing the trabecular meshwork outflow. Then we have Rhopressa. That was the one that was introduced in 2017. It's a Rho kinase inhibitor. It decreases the resistance to the outflow and helps the trabecular meshwork work more properly. But it's not as potent as the prostaglandin analog, so it might not be the first choice. Now they're going to come out in 2020 with a combination of the Rhopressa and the latanoprost, and a variety of these medicines are available where you have two drugs in one bottle, and that's because oftentimes as the disease progresses or as time progresses, you might need two medicines instead of one, so you can get them now in one bottle. Well, some people don't seem to get better with just using the drops, and those people might need some further kind of therapy. And the further therapy might be an in-office laser therapy. You can have what we call a laser trabeculoplasty, and that can be done. It's relatively safe. It's effective. It's going to cause a substantial decrease in the intraocular pressure, but the failure rate is about 10% per year, so the effects gradually lessen over a period of time. Now, some people have to go on to incisional surgery. Incisional surgery might be the first choice in people who are poorly adherent to therapy or have severe disease or who live far away from medical care. There are a variety of different kind of trabeculectomies. That's the incisional surgery that can be done. Now there are some minimally invasive surgeries that people are using, and they all seem to work. But fortunately, for the overwhelming majority of people, if you go and see your eye doctor on a fairly regular basis, then You can have the detection of the pressure going up, which is the risk factor, and that can be treated just like your high blood pressure can be treated before you have a heart attack. And that's the story about glaucoma. Open-angle glaucoma accounts for about 80–90% of glaucoma in the United States. Remember, you can develop glaucoma with normal pressure, so we don't make the diagnosis strictly on the basis of the pressure inside your eye. Remember, the pressure in your eye is sort of like the blood pressure. It's a risk factor for problems, but it isn't a problem itself. But it does seem to have some relation to the deterioration of those retinal ganglial cells. And remember, by the time it's diagnosed, by the time you have some visual field abnormalities, you've already lost somewhere between 30 and 50% of those retinal ganglial cells. Now, we have promising research, as I mentioned, on the AI, the artificial intelligence, and maybe it's going to be able to make the diagnosis at a relatively earlier stage, but that still remains to be worked out. For right now, it's making the diagnosis either on the basis of visual field changes or the increase in the pressure inside the eye or the changes in the back portion of the eye. And if we do that, your vision can be saved. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified as we post new shows. I appreciate your interest. I'm Dr. Ken Landau.